All right, let's go through this case in detail. We're examining antero-posterior and axial views of the right shoulder in a skeletally mature patient. The humeral head isn't articulating normally with the glenoid. Instead, it's displaced posteriorly and impacted on the posterior margin of the glenoid. This displacement has resulted in a large reverse Hill-Sachs defect in the humerus. The presence of sclerosis around the margins of the defect indicates that this condition has likely been present for some time, suggesting a long-standing issue. The acromioclavicular joint appears normal, the visible lung fields are clear, and there are no fractures elsewhere. This helps us rule out any additional complications like rib fractures or lung injuries. Based on these findings, the diagnosis is an impacted posterior dislocation of the humerus with a very large reverse Hill-Sachs defect, suggesting that the dislocation has been present for about 3 months. Such cases often require surgical intervention, so correlating these imaging findings with the clinical history and discussing the case with the referring clinician is crucial for planning the next steps, likely involving surgical reduction. Now, discussing shoulder trauma more broadly, the type of radiographic view is crucial for identifying dislocations. Dislocations can be hard to detect on an antero-posterior view alone. It's important to ensure that the curved articular surfaces of the glenoid fossa and the humeral head are congruent. If the humeral head appears magnified or minified relative to the glenoid, it may indicate dislocation depending on the direction of the beam and the dislocation itself. In general, it's best to avoid commenting too much on joint alignment from a single view. If the glenohumeral joint appears congruent on this antero-posterior view, reviewing the film with a second view is usually good practice. Alternative views, like the Y-view axial or the Garth axial oblique view, are valuable for getting a complete picture of the shoulder's condition. A comprehensive checklist for shoulder radiographs should include assessing for dislocation, including the acromioclavicular joint, fractures such as Hill-Sachs, reverse Hill-Sachs, and bony Bankart defects, pathological fractures, abnormalities in the subacromial space, rotator cuff calcification, erosive lesions, soft tissue abnormalities, and lung findings that could indicate injury or pneumothorax. The shoulder is the most commonly dislocated joint in the body, and understanding the features of each direction of dislocation is critical. While anterior dislocation is the most common, posterior dislocation, as seen in this case though less frequent, is significant and can often be missed in initial imaging. It's crucial to look for signs like the rim sign, where the distance between the humeral head and the anterior glenoid rim is greater than 6 millimeters, as well as reverse Hill-Sachs defects. Remember that the shoulder can also dislocate inferiorly or superiorly, adding to the complexity of these cases. In conclusion, this case emphasizes the importance of a thorough and systematic approach to diagnosing shoulder injuries. For those following along with Radiology Made Easy, I hope this detailed analysis deepens your understanding of shoulder dislocations and the necessary imaging techniques for accurate diagnosis.